at the end and then open it up for general questions. So it is my pleasure to introduce the first two speakers. Martin Goetz is a scholar of philosophy at Basel University in Switzerland. He works on bioethical issues and has participated in an interdisciplinary one-year project dealing with different aspects of biotechnologies and has studied philosophy and Islamic studies in Freiburg University. Manfred focuses on modern intellectual discourses in the Arab world. In his dissertation, he dealt with the liberal Lebanese religious scholars, Alibhai. He describes his dynamic interpretation of Islam, Shia, and ethics as an example for an Islamic criticism of hegemonic Islamic discourse. He was educated in Islam studies and sociology at Freiburg University. Please join me in welcoming them here today.
Thank you very much. First, I'd like to thank the organizers for their work and for their kind invitation. Then I would like to put emphasis once again on our scientific backgrounds, because I studied philosophy and focused on bioethical questions in recent years, but have only very little skills in Islamic studies, whereas Manfred has a PhD in Islamic studies. So already we somehow embody the constellation of this conference, and I think this is an aspect we could discuss more deeply afterwards, if you like. Just because from this point on we could look into how this interdisciplinary work functions in the end, personally and concretely, so to speak. The title of our paper is Structural Similarity of Islamic and Western Bioethical Discourses, and I don't want to give a summary here of this paper, but just try to say the same things in other words, more or less. So the purpose of our paper is to give a comparison of those two discourses, Islamic and Western discourses, and I think it is important to keep in mind what we are doing then, in fact, and that the level of where we speak is quite above the concrete problems on the bottom, and that there are several layers of discourses which are between them. So at this moment we could discuss already the question, is this chain of transformation of information from the concrete ethical challenges at the bedside, so to speak, up to our comment, is this chain complete, or are there any gaps between it, or is this transformation of information possible in the end? Perhaps some people would say that the shift from Muslims to non-Muslims perhaps is a very big gap or a very big problem to keep this transformation process at hand. The second slide tries to say the same things in the end, in other words, or give a picture of it, and wants to emphasize once again our method, which is meta-theoretical. So we did not read fatwas in the end, but we tried to think about how did people read fatwas and what did they say about them. After this, I would like to continue with the end of our paper, with the result of what we found out. And we think that, of course, it is easy to find differences between Islamic and Western bioethical discourses. That's the obvious thing. There are different languages, there are different authorities, a different semantic material, a different juridical framework, and much more. Different political situations, different political traditions and history, even different climate, and much more. But what we think is much more important is to see the common things, the common aspects of Islamic and Western bioethical discourses. First of all, of course, we share the same problems, the same bioethical problems, which in fact are how to find the final ground for our decisions. We try to construct coherence in our actings. We try to organize consensus in our societies, and therefore we try to obtain legitimacy for our actings. And we think that both societies use similar ways of how we construct norms and give responses to those ethical challenges, which is we try to derive actual answers for our problems from historical authorities. We have the interest to form a historical continuity and therefore an identity, an historical identity of what and who we are. And this way we organize a consensus in society and the coherence in our normative systems. So now I give to Manfred.
My part is to present the Islamic part of our comparison between what is Islam and what is Western. And I want to say that we try to establish a new focus, looking at the whole process of legitimization, means to make aware of the similarities between discourses in Western and Islamic contexts. The difference are overemphasized if Muslim responses to bioethical challenges are mainly seen to be embodied in fatwas. And what is this whole process? This whole process starts with the ethical problem, and this ethical problem is translated into different languages. There may be an expert in religious law or a philosopher, a politician. They all translate the same problem in different languages. And an economist may ask, what does it cost to behave ethically? And these languages are different. And inside of every language, of every framework, we have different possibilities. If you have two muftis, maybe you have three opinions. And therefore, you have to organize consensus. And there are different possibilities to organize consensus. National fatwa committees, for example, or transnational committees like the Muslim World League or the OIC, those committees, they try to organize consensus. That means consensus is not just there; it has to be established, and it is established either by authority or by majority vote. And after that consensus in this committee, this consensus is translated into state legislation or not. This is always an open question. And still, if the scholars say that a problem, an ethical problem, is a new biotechnological method is possible to handle, and state law allows it, and law allows it. It is possible that the social practices are different, that people behave in a different way than the the scholars say. So the legitimacy in the end is in question, and we have again the ethical problem, and the whole process starts anew, and we have an eternal discussion on this problem, and maybe we'll meet again in 50 years. So what I want to say by this procedure of legitimization is that its diversity between the practical and the opinion level, and between the popular and the expert level, for example. But on all these, and many of the papers here in this conference deal with this diversity, that people behave in a different way than jurists handle the problem. And the second point is, in all the steps of all levels of this legitimation process, these are Muslims who deal with these different steps. And if we then ask, what does Islam say about ethical problem, we talk about a very complicated process. And the third thing is, if we concentrate on fatwas, it's just that we concentrate on a part of the first step. We take out the opinion of a special part of experts, and this means we concentrate on just a single point in a whole process, and we neglect the whole process, and that means that the Islamic law, that the fatwa, this fatwa-centered approach makes 2 points. I want to make 2 points about this fatwa-centered approach. First of all, a fatwa-centered approach always produces differences to a Western, so-to-called discourse, because a fatwa-centered discourse, a fatwa-centered approach always embodies the semantic material and the cultural legacy of Islam. And that means if we study fatwas, indirectly we treat this process of legitimization as special Islamic. And the second point is that if we concentrate on fatwas only, we think that the challenge for Islam is embodied in those fatwas. And what we wanted to say is that the whole process is the answer, the response to the challenges, not just the fatwa in itself. We want to say that the conceptions of Sharia that emanate from a fatwa-centered approach are three. A social approach that says that the problem Islam faces is the contest between conservative and liberal scholars. So you just name scholars to describe a problem of a whole process. The second approach is a deficiency approach. You say Islamic law is a pre-modern or a sacred law, and you assume that it is different from a rational law, so to say. And the third approach is the inner logic approach. You treat Islamic law as a culturally defined framework, and you say this is as good as a rational law. But what we wanted to say is that Islamic law as well as, or sacred law as well as a rational law cannot go back to the source of the law. A rational law always upholds that it is rational. So a jurist has to say, I do something rational to legitimize his judgment. And a Muslim scholar says what I do is in harmony with the holiness of the law, but he cannot do a holy judgment. He draws a judgment from a holy text, but he only can uphold that it is in harmony with the holiness. So the source, the rational or holy or whatever source is not available for the judgment process.
Okay. We had two more slides about some philosophical or epistemological aspects, and I think we leave them out due to the time we've reached now. Okay, thank you very much.
Jonathan, are you doing the mic? Okay, so over here, and then in the front.
I know you guys have a very short time to do justice to your paper, so I enjoyed your paper. Your paper is very deep in analysis. I just have two questions for you. The first thing is about your slide about the process of legitimatization. In my recollection of the development of Islamic laws, the schools of law, fiqh, was that legitimacy was given through public opinion. And that you saw that in Dr. Hamdi's presentation, which was, she wasn't here, but how someone's opinion was legitimized in the people by they thought that this was the way to go, right? People give it legitimacy, not the government. And that tension wasn't necessarily reflected in what you're talking about. And that's how the schools of law developed. There were almost 20, or even more than 20 schools of law, and the four existent ones that we have in the Sunni schools were because people gave them authority, right? That was where the authority came from. And people bought into the arguments, people enjoyed them. And that's why one scholar's opinion can be much more meaningful to the people and affect practice more than a council's decision. That's one. And part two of that is you mentioned that if you think about Islamic medical ethics as fatwa-based, you lose a dimension, which is true. But the case-based approach of Islamic law also allows it to be malleable and flexible to the cultural context. And also, again, that's how it lends to the clinical encounter, where you can have a case-based approach, and you can really retain the context, and people can draw from different fatwa to apply that to their context. And part B of that is, you just mentioned, the last thing you mentioned was that you can't go back to those sources. And I would argue that if you, aside from biomedical ethics, if you look at other things, a lot of times a scholar, to find a decision, might consult a fiqh manual, let's say on ibadat, on the worship, right? As opposed to going back to the Quran and the Sunnah and trying to get the hadith, they'll consult a scholar's book, a Mukhtasar al-Khuduri or something, and draw the conclusion based on that manual of fiqh that was always existent. And we know that it's drawn from the sources. So everybody doesn't have to go back to the sources. I mean, this is not how law proceeds, but they go and build upon consensus, or they build upon the books that are already existent. Just like we have in the modern law, we have, or in the rational law, we have, what's it called? What? Precedent, right, precedent.
Well, perhaps I can start from the position of a non-Islamic expert. Our purpose was to compare two discourses. Well, the Islamic world, which is perhaps the question, what is this, the Islamic world? But we talk about it here, so it must exist, obviously. And on the other hand, we have the Western world, and there already we are used to make some kind of special science to show that we do not know what this is, the Western world, and we are. And there's a lot of hesitation to talk about this Western world, because we all know that already between us two there are big differences. So, but nevertheless, we try to compare those two, because that's what we're doing here, in fact. perhaps inexplicitly because we only speak about Islam, but under the table the Western world is there as well, and so we do this comparison continually. Yeah. And now, well, what you said just once again convinces me that the differences between you and me, just as representatives of those two worlds, are not that big. Because, as you said, Islamic law tries to follow precedents, just as the case law in the Anglo-Saxon world, and well, similarly to the kind of law in Europe, and there again, I think, as you said, we have the same methods, the same ways of solving our problems. So that's from my position.
For that point of going back to the sources, that was meant to say. I wanted not to say that it is impossible or whatever. I wanted to say that it is possible, but it is all possible in different ways. The first problem that a religious scholar has to deal with is when he tries to solve bioethical issues, is to find a basis and a starting point for the argumentation and for the education of a norm, and the connection of a bioethical problem with a hadith or a Sharia rule is indispensable strategy of rationalization, and it constructs a connection between his judgment and the basis. But there are always different constructions and different starting points possible. So you always have muftis that deal in different ways. As you said, there were 20 schools, and so even if the sources stem from the holy book, you have the problem how to deal with the sources.
Thank you. One of the things I'm struggling with is to understand whether some of this legitimatization that you're talking about within Islam goes back to the church versus state concept within sort of Western development of modern thinking and law, such that the religious influence over the last few centuries, particularly since the Renaissance, has become less and less, although there was clearly a significant formative influence within Judeo-Christian values on the legal system. And using that as a lens to look at legitimatization within Islam forces you into a certain analytic structure. And I'm not sure if there are problems within that structure or not. I don't know the answer. I'm trying to think about whether you've considered that and whether that impacts on your analytic method and the conclusions you draw from your meta-theoretical approach.
Well, if I understood you well, it's you have. Do you think that there are that religion and or that the relationship between religion and state in the Islamic world is different from the Western world? Well,
depending on the country.
Yeah. So there again, it depends on the country. It depends on the local situation. It depends on the methods or ways of influence you want to talk about. Because, well, I'm not American, but I think that some Christian groups in America have quite a lot of influence on the politics of this country in the end. So perhaps not in the same way as the muftis do, but there is this influence. So so there again we have the same structures. We have perhaps you may say that in some Islamic country religion is more important than in some American state concerning some special issue. But this may simply be the other way around if you look at another issue. So I don't think that there is a general difference.
Unfortunately, in the interest of time, we're going to have to move to our next panel. So,
Okay.
Shuffle. And if you can you give me that name tag? Just turn it off. While they're setting up for their session, I will introduce our speakers for the next part of the panel. Dr. Alibhai is an assistant professor in the departments of medicine and health policy, management and evaluation at the University of Toronto. He received his Master's of Science and MD degrees at the University of Toronto and has written extensively on religious ethics and end-of-life care. Michael Gordon is the current Vice President of Medical Services at the Baycrest Center in Toronto. He's also a professor of medicine at the University of Toronto and has published several journal articles on ethical decision-making in geriatric care, and has also authored several books on caring for elderly patients. His latest book, Parenting Your Parents, Support Strategies for Meeting the Challenge of Aging in the Family, was published in 2005. Please join me in welcoming them.
Thank you. Thank you, and it's a real honor, I think, for both of us being here. Shabbir and I go back. He reminded me 15 years when he was a student at the Baycrest Center, and since that time we have shared many activities, including ethical discussions comparing Islam and Judaism, and have managed even to do some writings on the subject. This particular presentation is an outcome of a presentation we did at an American Geriatric Society meeting, where in fact we did Judaism, Islam, and really Catholicism, and looked at it from the three monotheistic religions, but we condensed it for the current presentation. So the way we're going to do it is going to be sort of a tag team, and I'm going to look at the Jewish perspective and Shabbir the Islamic perspective. Principles of Jewish medical ethics, and I'm not a scholar, but I've put a lot of effort into trying to learn about Jewish medical ethics because of the organization in which I work and also my own interests. Medical ethics are based on concepts of Jewish law, so-called halacha, which means the way. The sources of the Torah, the original 5 books, are the most authoritative, the Talmud, which are the commentaries, and then we have responsa, which are scholarly opinions on the previous 2. Halacha has ancient roots. Recent resurgence of ethics in medicine and Jewish bioethical inquiry refers to the principles found in the scriptures and the commentaries and applies them to contemporary decision-making. It's a very iterative process. Previous opinions often form the basis of current discourse, which is very similar to case law, in that things are built on what opinions and activities have occurred previously. The basic tenet of halacha is that the interpersonal behavior traditionally conceived as the execution of duties within relationships, which is somewhat different from a typical rights-based approach to human interaction, and which is often the case in the secular world. And the performing of mitzvot, which really means good deeds, it's not charity, it's your obligations and duties, in fact, is a way that we basically govern the way people are supposed to act in relation to each other. The important halacha concepts and approaches within medical ethics are: 1, the rabbi is a teacher, an interpreter, and an expert counselor, but is not really an emissary or a representative of the deity. There are obligations as a physician. You're not obligated to become a doctor, although our mothers probably thought so. But once you are, you're obligated to heal. And the nice part, as a patient, you're obligated to be healed. So the duality in the classical sense is great, although obviously people deal with it somewhat differently now. Sanctity of life is paramount. Human life has infinite value. Illness and death are a natural part of life, and one is duty-bound to save of life short of committing murder, incest, or public idolatry. Humans are responsible as stewards of their bodies, and autonomy is not the paramount ethical principle, but community values are very important. Relief of suffering is very important. Duty to care for one's parents in old age, it's one of the commandments. The process of dying is very important and must be respected when clearly occurring. And major contemporary challenges is not so much the interpretation of halacha, it is determining when hope for life has to be replaced with the allowing of death to occur, the condition known as a goetz, a dying person. Now it's Shabbir's turn.
Good afternoon. It's a pleasure to be here along with Michael, and I'll echo his comments that I also am not an expert in religious bioethics as much as I'm a clinician who is forced to struggle with bioethical issues on a daily basis, and to understand my responsibilities as a Muslim physician and to advise those patients of mine who are Muslims and ask for guidance. I have struggled with trying to understand these issues, and I come here to learn as much as to teach, probably more to learn than to teach. And I had made the assumption that you had received our article ahead of time, which I do apologize for those who had not. So given the nature of the audience, most of you know the principles within Islamic bioethics, if such an entity exists and we agree upon that, well enough that I wasn't going to cover them. I was only going to very briefly mention the key principles derived from a couple of key ayat in Quran, one of which has already been alluded to, this one and another ayat in Surah 17 that deals with the notion of sanctity of life, and that every moment of life is precious, and that Allah is the ultimate arbiter of reality, arbiter of the moment of life and the moment of death. And until such time, every moment of life in and of itself, whether conscious or unconscious, has some intrinsic value and preciousness to us. It is also our duty as Muslims, whether physicians or patients, to seek out cures and treatment for illness as well as to prevent illness. You have heard earlier the hadith from Sahih Bukhari that there is a treatment for every illness. Some of you may also know that there is an alternative form of that hadith that says there's a treatment for every illness except old age, which has relevance to geriatrics. But there's also an issue of duties and rights. Although we all have certain duties with respect to being healed and seeking out healing, we also have rights to expect of the physicians and other caregivers who provide for us. Again, autonomy is a much lesser issue within Islam, and the notion, the terminology itself, as you've heard earlier, doesn't really appear in many languages that are commonly used by Muslim communities. And suffering has significant value. There's redemptive value in suffering. There is value in and of itself from Allah. At the same time, human beings are permitted and in fact encouraged to seek out the relief of suffering, which is embodied within the physician's oath, the Islamic version of the Hippocratic Oath. And there is also a sacred duty to provide nutrition and hydration beyond the notion of treatment itself, some of which I'll be getting into in a talk tomorrow dealing with end-of-life issues in advanced dementia.
And then what Shabbir and I decided to do, since we're both clinicians and deal with geriatric patients, is to use cases, and use sort of in the sense of case-based learning and case-based teaching, some cases that are very common, typical, prototypical, and we'll respond to them from the Islamic and from the Jewish perspective. So these are some of the cases. So case one is an 86-year-old cognitively intact woman with heart disease, emergency admission for massive stroke. 2 months later, remains unconscious with completely paralyzed on one side. Neurologist says no recovery likely. Religious family, they request a feeding tube, a G tube. She develops pneumonia. The children say do not tell her husband of the bleak prognosis, it will kill him. And the husband keeps asking for information. And the case questions are, is it appropriate to insert a feeding tube? Should her pneumonia be treated? And how will you respond to the husband's queries? So trying to look at it, this is a prototypical. You can have 5 rabbis, as I said earlier, and you can get 5 responses, but this would be a sort of classical response of most knowledgeable rabbis dealing with the situation. The insertion of the feeding tube would be required because feeding a person who is not clearly in the process of dying, as told Goetz, is obligatory. And sometimes, and this is more a reflection of modern, you might look at it in a construct of a trial period to see what will happen that allows you to take another step if necessary. The treatment of the pneumonia would of course be required, saving a life, again, that isn't in the process of actually dying. As for telling the husband, probably yes, if couched in a way that is positive and hopeful. There is, however, within Judaism, a reason to withhold bad news if it is believed that the person receiving it is ill and clearly at risk of severe consequences. Otherwise, truth-telling is expected and trust is maintained. It would be a very unusual circumstance that you might be allowed to withhold the truth only because of potential immediate harm, not the idea it'll kill him, sort of generically.
from the Islamic perspective, similarly, the notion of inserting a feeding tube would be one in which I have posited in the other article as well, that this would be beyond the notion of medical treatment and would fall back upon the concept of what is considered basic care. And part of that basic care includes a duty to provide nutrition and hydration to individuals through means such as a feeding tube. And in this circumstance, this individual is not immediately and imminently dying, and the risk of the feeding tube, unless the likelihood is that inserting that feeding tube is going to lead to premature death, it would be, at least in the opinion of the majority of scholars that one would read, would be considered strongly recommended, if not obligatory, to insert that feeding tube at that time. If you can preserve life and prolong life, the argument would be even stronger, but it is not a necessary condition for insertion of that tube. Similarly, the notion of treating the pneumonia, again, you're dealing with a potentially reversible illness in the setting of a person who is ultimately otherwise unwell. At the same time, that illness is potentially treatable, and in order to try to preserve and prolong life, given the preciousness of life, whether she is conscious or paralyzed, we would be obligated to seek treatment and to attempt to treat that pneumonia. And finally, the issue of telling the husband. While we recognize that we don't want to give people bleak prognosis, at the same time, telling the truth is an important concept within Islam, and withholding information has limited basis, particularly given the hierarchy of substitute decision makers. For a married woman, her husband is her substitute decision maker, unless there's specific circumstances within a secular will or other system. He would need information about her condition in order to be able to provide information about her ongoing care. Providing that information in a gradual, limited fashion, whatever he needs to know, without trying to sugarcoat the truth, is something that would be the general Islamic position.
Yeah, we often say it's not what you tell, but how you tell it that really matters. Now, case 2 is an 84-year-old woman with mild dementia and heart failure. She's admitted to a nursing home. Husband provides an advance directive stating no CPR, no cardiopulmonary resuscitation, no antibiotics, and no transfer to acute hospital. So this came from the patient, the woman, prior to her becoming ill. And in Canada, that would have a very strong legal position. How should the staff respond to these requests, especially if they go against their own religious convictions? We have a multicultural, multi-ethnic society in Canada, and many members of the healthcare community may have different feelings about many decisions. The patient falls ill and is in a stupor state secondary to sepsis. How should the staff respond? Question number 1. The response of the staff, the surrogate decision maker is the person to whom the advance directive speaks. It's not the doctors, it's not the nurses, it's to inform the substitute decision maker. That's the way the law, the secular law in Canada is framed in most Western countries. If the husband believes that her requests do not contradict her religious convictions, no problem. If he has a concern, he might have to get some advice from a rabbinical scholar to try to determine the relationship between what was in her advance directive and maybe what her religious belief system was prior to becoming ill, to see if it in any way contravened halachic framework. If Orthodox, she may have requested at the time of her advance directive to actually have rabbinical input to make sure that it was congruent with the halachic framework. In the case of stupor, the surrogate would still be expected, allowed to make decisions. No decision for the staff. They are really not part. They are to respond to what the family, what the patient and the surrogate would indicate. And even though halachically they would normally require treatment if there was a chance of survival, a patient or surrogate can refuse treatment, especially if the outlook is so very poor long-term and if the treatment is of questionable value. This is an area of some dialogue within Judaism. Rather than being a gosses, which is an imminently dying person, it's called a treifa, and that means something from which the suffering is a fatal organic disease, recovery of which is impossible, but the period that it may take is longer than the imminent dying process.
So the Islamic response to this would be, first of all, with respect to the wishes contained within the DNR, there is no compulsion, as you've heard, in terms of the convictions of the staff. We would not be expected as Muslim staff to be forced to do something against our own convictions, but at the same time, we would have to respect those individuals' wishes. We cannot impose our decisions on them if we disagree, would be the understanding and the position that I would promote. However, we would clearly draw the line in situations where we would be asked to do something such as active euthanasia or similar situations in which Islam would have clear and strong opinions about this being equivalent to murder. With respect to the issue of the patient falling ill and becoming stuporous, the situation really hasn't changed. If there's no reason to believe that the patient's underlying wishes have changed since the advance directive was written, then it is certainly reasonable and permissible to follow the directives and treat the sepsis, even if it goes against one's own beliefs, because one may think that the patient is suffering and that we should no longer provide active care. There are some articles that have recently been written suggesting that Islamic living wills are quite acceptable and appropriate, and there's been a number of analyses. And in some Muslim countries and in North America, there are some Islamic forms of living wills that are surfacing, suggesting that this idea is starting to gain popularity. We have a third case, but should we stop?
Yeah, you should stop.
Okay.
And we have time for questions.
Discussion. Now, of course, you could ask us for the third case. How's that?
There's no setup from that one. I'm not going there. Of course, as a physician, I'm partial to the case-based approach. One of the things that does not come out in the paper is the possibility of heterogeneity within the community. Not being so familiar with the Jewish community, my interaction with that community was with a large Orthodox community in Baltimore, where I trained. We recognized that there was some degree of heterogeneity. Certainly within the Muslim community, there is a substantial amount, some of which is geographic, ethnic, different denominations, and then within the denominations, even schools of thought and approaches. Can you talk about sort of how, as practitioners, you had to deal with that? You mentioned these were a composite of cases, but the reality is that proposes a real challenge into the actual practice.
I'm going to try to give a summary, and the people could challenge it who maybe know more than I do. Within Judaism, halacha actually crosses, if you want to say, the spectrum of reform, so-called, to conservative to orthodox. So the law is the same. There is some, you might say, flexibility in interpretation, but I haven't found to be that profound. The real issue in Judaism is not whether there is built in, it's who you ask. And who you ask matters a lot because you can only get one opinion. If you want a second opinion from the person you ask, you have to ask the person to change their opinion, not go to another until you get the one you want. So it matters. Now, there is a range, even within orthodoxy. I worked in a very orthodox hospital when I lived in Israel, and we knew the two rabbis of the hospital actually were somewhat divergent about certain areas. So if you had to get an opinion, you tried to wait to see who was on call. Because you know there would be some degree, although all within a framework that you could say that resonated properly with halacha. So there's a core of fundamental belief and some interpretation, but the interpretation is less the spectrum of reform to conservative or orthodox than the rabbis themselves and how they have interpreted it, as in the legal system. The secular legal system.
Within Islam, the struggles are very similar. You're absolutely right, and for reasons of space, we didn't get into this. Clearly, there's significant issues around particular interpretations within given cases. We recognize that there are general principles within Islam, obviously, in terms of preserving life and the sanctity of life, but different religious scholars, different communities, different cultural and ethnic groups will draw different boundaries in terms of when is it reasonable to stop. Because Islam, many people have talked about Islam being on neither extreme, that there's moderation, and at some point you have to stop, active treating and saying it's time to basically let the patient be comfortable because they're dying. How do individual people, individual communities, individual imams who advise those people come to that decision is very difficult. And what I've had to do in practice and what my colleagues in Toronto and other cities have done is we've gone to that to the community that that individual holds dear to them, the one that they are closest to, whether it's one of the formal schools of thought or whether they say, well, I'm within the Somali community, I'm within the Pakistani community, I'm within the Iraqi community, and try and find scholars that they respect within that community to help us in that decision making rather than impose from on high. Because as you've heard many times today, and as you've already alluded to in your question, often the particular group in the school of thought has an influence in terms of where they answer the question, where they lie on the spectrum. And for us to assume that there is one answer is naive. You're absolutely right. And if that didn't come out in the paper, we should be clear on that. So thank you.
Thank you. Dina Davis from Cleveland State University. I think I'm going to push the previous question a little further. I saw two areas of, to me, tension in your discussion of the cases. And beginning with the Islamic one, you talked about the importance of keeping the husband, in I guess the first case, up to date on what was going on because he needed to know that to make decisions. And that surprised me because nowhere else in your discussion did you suggest that the patient's wishes were relevant. You never mentioned the patient's wishes at all. So if we don't care what the patient thinks, why should the husband need to be up to date? So that was the tension that I saw in yours. And moving to the Jewish one I had along the same theme, I frankly, you know, in the interest of time, let me put this bluntly, find it a little bit offensive that somebody who went to the trouble to make a living will and to be fairly specific, that someone else should try and second guess her because she's no longer competent, and to say, oh, well, what does halakha say? I mean, she decided what she wanted to do, and as we saw from a number of the presentations before, people may quite thoughtfully not do what particular experts say and still define themselves as Orthodox Jewish or, you know, Muslim or whatever it may be, but this is their particular individual understanding of how they want to govern their lives with respect to that. Thanks.
Shall I take the Islamic part first?
Well, you do the first,
Sure.
and I'll answer.
So I thank you for the question. I think the tensions arise from two sources. The first is that we recognize that even within Islam, although there are differing opinions, there's also different levels of observance, and that different patients and different groups, different communities, what have you, will have differences of opinion, and that they may or may not decide to see things the same way in terms of how aggressive to be. And so within our case-based approach, we recognize that in practice, we cannot dictate to the patients what they should do. If they ask us, we can certainly provide information. I bring these cases up to present the struggles that people have and to recognize that in the environment where we're in, it is obligated on us to ask the patient or whoever speaks for them, if the patient cannot speak for themselves, where do they draw the line, whether they draw it on the basis of a formal fatwa from a mufti or whether they draw it on the basis of a set of family values or other values, but that without that interaction, given the plurality of opinions and the diversity, we cannot assume that people will see things one way. The second tension relates to the fact that we practice within Western environments in which autonomy is recognized. Rightly or wrongly, autonomy is an important principle, and by law, the colleges that dictate the practice for most physicians will say that we must speak to the patient and determine what their wishes are. If they say, I will defer to the religious authority here, I'll defer to my husband, I'll defer to the doctor, what have you, but they have to make that decision. They are their substitute decision maker. And this is the reason why advanced directives have started to become popular. One, to clarify so that it minimizes the confusion as to what that patient would want, but also because we recognize that there is such an intersection between Muslims and non-Muslims in a complex environment that we need those opportunities, and it does create some tension, but it's opportunities to explore and understand what the wishes are.
Can I answer the part that was directed to me? Thank you. I could give you a whole talk on the limits of the advanced directive, because that's an area of interest of mine, but maybe the law is different in the United States. In Canada, in each province, the advanced directive speaks to the substitute decision maker, not to the medical staff or the nursing staff. It's to inform us how to make the decision and for us to interpret it. And what I have actually found is most living wills do not help the caregiver make decisions, except for some very limited specific things. And I can give you, as Jack Benny would have said, a million of them of the examples. But the fact is that at the end of the day, it's the surrogate who makes the decision and uses the advance directive to inform the decision. And if you as a healthcare provider think the person is doing a major disservice based on a living will, you'll have to challenge their surrogacy and demonstrate that they're not acting either in the best interest or as the true meaning of what that advance directive is supposed to mean. So that's the way the law is structured in Ontario, and I think most ethicists would say that's the principle embodied in the concept of an advance directive.
Alas, we've run out of time, so we will have to move on. Stef Branden graduated in 2002 from the Catholic University of Leuven in Belgium with a master's degree in religious studies and is currently working on his PhD dissertation. He is a co-researcher at the Interdisciplinary Center for Religious Studies at the University of Leuven. Please join me in welcoming him today.
Thank you. Dear colleagues, dear audience, and since this is an internet emission, I would like to take the chance to greet my family, friends, and colleagues in Belgium, my wife and my child. Hello. Thank you. So as you received the papers, I shall not repeat the content of my paper. What I will do now is I will address some key issues and provide you with more background to the paper. As I do tend to mumbling, please announce this if it happens. It's no offense taken. So religious and ideological affiliation do have a considerable impact on attitudes towards ethical decisions surrounding the end of life. However, until now, little in-depth empirical research has been conducted in this area. Now, in the limited amount of research on the influence of religion on ethical decision-making, the factor religion was invariably operationalized on a rudimentary level only. Very little attention went out to the attitudes of minorities in society in relation to their ethical and end-of-life decision-making. So the importance, still the importance of ethnic minorities did increase significantly. During the past 40 years, millions of migrants have settled in Europe, resulting in a wide-scale demographic and cultural change for European societies. In Belgium, just in a majority of Western European countries, Islam has become the second largest religion. Of course, it's always difficult to assess the correct number of believers in Belgium, since the Belgian National Institute of Statistics is not allowed to ask for religious affiliation in their census research. So we can only work with estimated numbers, as shown on the slide. As a result, palliative care in Europe can no longer cling to a Christian or a secular conceptual frame of reference as a touchstone. However, this turn of events fails to be reflected in public debates on euthanasia in Belgium or in any of the other Europe-wide biomedical debates. The Islamic vision is entirely lacking in any of these discussions. My research focuses on the way in which elderly Moroccan men living in Antwerp deal with all kinds of ethical decision-making at the end of life, including ethical dilemmas as severe pain control, various forms of withholding or withdrawing therapy, and euthanasia. I limited this paper to the link between respondents' faith in God and their view on the use and effects of medication surrounding the end of life. On the next slide, you can see the methodological choices we made in conducting this explorative research design. So we spoke with Moroccan people, not Turkish people. We spoke to elderly people, aged 60 or over, not with youngsters. We spoke with men, not with women. And we spoke with people who are living in Antwerp. So not in Brussels, not in Ghent or any other major city in Belgium. In fact, Antwerp is a city in Flanders, the Dutch-speaking part of Little Belgium. It is important to know the background of these people. All of them took part in a major labor migration starting in the 1960s. The Moroccan people who are now living in Antwerp have their roots in the northern Moroccan Reef Mountains and the adjacent rural areas between the mountains and the coast. So that's an area ranging from Tétouan over Tanja and Al Hoceima to Nador in the far east of Morocco. The majority of them had a very basic education, are often illiterate, and came to Belgium to work in coal mining companies, which was hard work that Belgian people no longer wanted to carry out. The results of these characteristics is that the Moroccan migrants belong to lower social classes. They form a close community not well integrated into the Belgian society. Speaking about the first generation Moroccan men, the most apparent lack of this integration is their inability to speak Dutch. Although we acquired a basic understanding of Moroccan Arabic, these interviews had to be conducted in close cooperation with a sworn interpreter who has a thorough knowledge of both Moroccan Arabic and Rifrian Berber, as the majority of these respondents do not have Arabic as their mother tongue. The gender of the interpreter and the researcher provided for the research limit to male respondents. Additional interviews were taken with two important imams, ulama, and two Moroccan general practitioners, all living and working in Antwerp. These additional interviews were conducted for checking the external validity of research findings. So I conducted semi-structured interviews with 15 respondents. I took 2 interviews per person, each interview lasting for about 1 hour, up to 1 hour and a half. In total, 30 interviews were conducted, which is a common number as compared to international standards in qualitative research. Then, applying Glaser and Strauss's grounded theory methodology, every interview was fully transcribed, coded, and analyzed. New questions rising in the analysis of the first interviews were taken up in the course of the interviews to come. This way, the ideas encountered were thoroughly tested throughout the research process. In the semi-structured interviews, we used very clear-cut operationalizations for both the factor religion and the factor ethical decision-making at the end of life. For the factor religion, as there are no duly tested research tools available to measure the religious attitudes in Muslims in a migration context, we have endeavored to compile a workable operationalization of religion adjusted to suit the target group. And this was based on the 5 traditional dimensions by Glock and Sterk. To these 5 dimensions, we added a 6th dimension, which assesses the. I have to read that one. The interwovenness. Thank you, with the religious community. I call it the social dimension. And of these 5 traditional dimensions, the ideological dimension was left out, so we ended up again with 5 dimensions. I provide you here with some example questions that were also stated in the research paper itself. And the factor ethical decision-making at the end of life was operationalized as medically assisted death, as based on the typology by Brookhart. Central to this typology is the distinction between active and passive life-shortening or life-terminating actions. The passive form consists in withdrawing or withholding a life-prolonging treatment. The active form consists in active administration of medication with a life-shortening effect. Within the passive form, Brookhart distinguishes according to the reason for the withholding of or withdrawing of a life-prolonging treatment. So the decision can be taken because it's the patient's wish or for medical ethical reasons. Within the forms of active life-shortening or life-terminating action, Brookhart distinguishes between active termination of life versus symptom control and pain control, with life-shortening effects, with palliative sedation as the most radical form of symptom control. The final group, as part of typology, is constituted by 3 forms of active termination of life. These forms are euthanasia, active termination of life without request, and assisted suicide. We made this typology operational by creating easy understandable cases. For exact definitions of the term used, I refer to the research paper itself. These 2 operationalizations provided for a firm methodological basis in this research. As to the results of the interviews with the Moroccan Muslim men, aged 60 and over, We saw that there's a very strong focus on the Almighty God and the afterlife. The Almighty God's central importance can be seen in the respondent's vision on illness, recovery, medication, and physician's role in the recovery process. The effects of medication and the physician's role are both placed second to the Almighty God's will, who seems to be the only authority which can really cure mankind. The apparent denial of the direct effects of medication can also be found in the respondent's attitudes on ethical decisions at the end of life. So radical pain control does not pose an ethical dilemma for the respondents, for only God controls the process of dying, and euthanasia, on the other hand, is totally unacceptable. Instead of accepting the intriguing mixture between the medical effort's relative effects and God's decisive role, in euthanasia, humanity claims a role to which they are not entitled and shamelessly denies their dependence on God. Moreover, in performing euthanasia, they explicitly refuse to submit themselves to God's will. Now, the results of this research are to be understood against the background of the palliative care research, which is a core interest of the Interdisciplinary Center for Religious Studies, the ICRS. The director of the ICRS, Bert Broekhaert, has made research on religion and ethics in a multicultural and multi-religious society into the research axis of the ICRS. In its research on several important manifestations of religion in today's multicultural society, the ICRS pays special attention to Islam, Judaism, and Buddhism, who are, along with Christianity, of course, the major world religions present in Belgium. And that the majority of these researchers focus on ethical decision-making at the end of life is a result of Broekhaert's firm research expertise in palliative care. On the former slide and on this slide you can see the most important end-of-life research that has been conducted at the ICRS. And the expertise of the ICRS is also firmly anchored in international Europe-wide research on the topic, as presented on this last slide. So this way, the research currently presented also has a strong international dimension, the most innovative aspect of it being the interdisciplinary and empirical methodology for introducing the multicultural and multireligious character of the Belgian and European society in palliative care research. During the closing session on ethics of the third research forum of the European Association for Palliative Care, the organizing committee appointed the implementation of a multicultural and multireligious dimension in ethical reflection concerning the end of life as a dire necessity, a call to which this research is willing to respond. I thank you.
Do we have time for questions?
Thank you for a very stimulating talk. I imagine you got a lot of joy out of doing this research. Some of us have tried and perhaps not been able to get as much as you did. I have two questions on this for you, methodologically. The first is, you mentioned that there's no religiosity measure within the Muslim community.
There's, excuse me?
No religiosity measure that has been validated within the Muslim community. So did you analyze your data in terms of that, from how people respond to that measure that you created? And was there any difference in responses based on that measure that you had? Hence, I'm asking you, is it going to be validated through your study? And then the second correlate to that is you made cases again from this data that you got. And again, the cases weren't validated. So my question in your work, because if they're going to be, this study shows some sort of validation measure, other people might be able to draw upon it. Those are the two questions I have.
Okay, thank you for the questions. First of all, I want to mention again that this is an explorative research design. It's because the very first research that has been conducted this way in Belgium, and I guess also in other European countries, at least on palliative care issues. So it is clearly not my attempt to validate these instruments. But the purpose of using these instruments can be for other researchers to draw upon it and to refine them further. So they can be elaborated. Also, more research has to be conducted with other Muslim communities, other Muslim groups, as these results are not to be generalized for the whole Muslim community in Belgium. Is it an answer to your question?
My question then becomes, how do you interpret the data? Why? Because the question always, people have put forth cases sorry, people have put forth cases. They've done a lot of studies in the States, I don't know about Europe, that people have put forth cases to Muslim physicians treating their own. And when you put that into a peer-reviewed journal, they ask you, well, where did you get these measures from? How do we interpret your data? What is this going to mean to us, right? Because they're not standardized cases. And then the question is, how do you measure visibility within the Muslim community? So my question then becomes, if these, I mean, you did this seminal work, what does it mean to us from the data that you got? How can we interpret that, not to generalize it, but to build upon it even?
Mm-hmm. So the framework we got these questions, we based these questions on. First of all, Glockenstier's instrument is a very well-known one. It's quite general, but it's up to this point the only one we can really use. It's a standard, and it has not been tested in migration context. But it's the only thing we have, so it's better than just go out and ask some questions. As to the generalizability, you can only come to a more general approach by conducting more research and using the same methodology, grounded theory methodology. You can start comparing, and you start reaching a higher level of abstraction, which can make it possible to validate the research measures.
We do have a comment on all of these sessions, so perhaps we can move to that, and then we'll open up for questions for all of our panelists. Oh, you had one. Well, I guess I'll let you have one.
Is this, there we go.
It's on.
My question, in your paper, you mentioned that you were interested in finding secular Moroccans and had a difficulty in finding them and locating them. I'm interested in what you thought you would learn from them, and also if you could speculate on the difficulty you had in locating such people, and how are you interested in pursuing that further, and do you have ideas about how you might alleviate that problem?
Okay, thank you. First of all, what I was looking for is another framework behind their views on ethical decision-making at the end of life. Since the respondents we talked to are all observant Muslims, I was wondering whether it would be theoretically possible to find Muslims of the same age, of the same community, who are not attending mosques, and I was wondering whether it would be possible that they share a more an approach that's more common to the general Belgian approach. But that's only a hypothesis. It's only a guess, no more than that. Excuse me, can you repeat your second question? Second part.
Do you have intentions then to go back and try to include this data?
In the meantime, I tried to do that by contacting several organizations, and all of them assured me that I could count these people on one hand. So, although the respondents in this research I've been talking to, they told me that there were a few of them, but none of them would really help me to getting in touch with them. They would at the least the most thing they would want to do is provide me with a telephone number, and that's all. But that's very most, and I did not receive any phone number until now. So.
Because of the interest of time, I'm going to go ahead and have our respondent at this point come up, and then we'll open it up to a few questions at the end. Unfortunately, I don't have a biographical statement for you, so I'll have you introduce yourself.
No, it was in the previous session,
well, okay.
so I say Ibid.
Okay, perfect.
Okay, I was supposed to respond to 3 excellent papers. So instead of criticizing or repeating what they said, I decided that from each paper I'll pick 2 or 3 points that were most interesting and maybe should be carried further in research or in debates and so forth. So I'll go by the order of the papers as they were presented. First of them was the paper by Goetz and Singh, The Structural Similarity of Islamic Western Bioethic and Islamic and Western Bioethical Discussions. You mentioned in one of the papers there, in one of the points, that the single mufti is losing power and the decisions are moving to more like committees. And I agree with that. And I think that maybe this is because the problems are becoming more and more complicated. And the committees are combined of physicians, religious scholars, lawyers, and the issues are even more interdisciplinary. So they have social aspect, they have a medical aspect, they have legal aspect. So you need all these people together in those ethical committees. And I know, for example, that in Israel, where you have a multicultural religious patients and physicians, most of the decisions would be taken not by a singular, either rabbi or doctor or someone like that, but more like by a committee, and they make sure that a religious leader from one of the patients, from the patient's community, whether Muslim or Christian, of this denomination or another, or a religious Jew if he is, then there will be someone represented from that sphere to give the input of the religious aspect. Another speculation that I have, why committee and not a singular mufti, is maybe a problem of the modern world. No one wants to take responsibility by themselves. And maybe we don't have any more scholars in the magnitude of Rashid Rida and Shaltut and people like that can stand by themselves behind an opinion, and most of them would like to consult others. With regard to the question of brain death, is this death or the end of breathing and heartbeat, is this death? And it all amounts to the question whether there will be organ donation or not. I think that we'll never come to a final conclusion on this issue. What is death? Some would hold one opinion and the other one would hold the other. But another question that is not asked is, let's say that we accept the fact that brain death is death. Is it true then that everyone that is brain dead donates or ready to donate his or her organs? So the next question should be, what is the motivation for donation once the brain death issue is resolved? Why would one donate and the other not? Or what is the motivation of people to donate at all? There was an interesting study, actually a PhD, that was presented in Haifa in 2001 by a sociologist and by two sociologists, one from Tel Aviv University and Dr. Arif Abu Rabia, who is an expert on Bedouin studies, and he represented the problem of getting Bedouins to donate. So apparently, once we resolve the brain death issue, we still need to find out why don't people donate more than they do today. Now, when we speak on human dignity, human rights, I agree that everything is relative and everything is dynamic. And it's very difficult to predict what among the values that are recognized today as human dignity will remain as such in the future and will win an ethical debate then. Okay. I agree with the result of the researchers that there is a very strong similarity in the structure between the Western and the Islamic ethical systems, and it is important to remember that the result of the process of seeking or searching for the norm is also not eternal, and it is possible to rephrase from each time again. This is a quotation from page 35 in the paper, and I add to that that the fatwa, which is changing from place to place and from along the time line, the fatwas are also evidence for this relativity of the crystallizing norm. In other words, the fatwa echoes social, religious, and other developments. And I don't know if Shaheen is here, but I don't agree with his putting down the fatwa. So ethics in general, I think, is a relative wisdom, and it's relative to time and place and to the nature of the sources that the ethicists rely on, and to the education and framework of those who phrase the ethics come from, and also to social and political pressures. And therefore, I think the result is that the fatwa should be examined every several years on an issue again and again, and not get a fatwa and say, okay, this is the position, and draw a line underneath it. It may be changing. I'll move now to the comparison between Judaism and Islam, the paper by Alibhai and Gordon. You speak of the 4 principles of Beauchamp and Childress: autonomy, beneficence, non-maleficence, and distributive justice. And I think that the 4th one has not been studied enough, the distributive justice. And I mean, especially in Islam, I don't know, I haven't followed that much, how much of it has been done elsewhere, but the question of how do you distribute resources? How do you divide the little that you have? Do you divide the resources equally between young and old? One of my students is writing a PhD on self-destructive aspects in Islamic medical ethics, and the question is whether someone who is taking drugs or someone who is an alcoholic, should they receive the same treatment, let's say the same liver and the same waiting time to be transplanted, like someone who never took alcohol in their lives whatsoever? And is self-destruction influencing the resources? The whole economic issue, by the way, in Islamic medical ethics has been so far very minimal. The issue of money, I don't know why they are ashamed of talking about money. In the West, by the way, they're not ashamed of doing it. All I saw is in one case, then they said, what do you do if you have only heart available for transplant and there are several people awaiting the transplant, and they suggest to draw like a lottery, something that they send us back to the Sunnah of the Rasul. In a different issue, when he had to pick the wife that will accompany him on a particular travel, then in order to do justice to all of them, he'll draw some lots and pick the one so that he will not have to bother with the rest of them. And this is mentioned in some of the sources, despite the fact that gambling, lottery, and everything is completely forbidden and is not viewed as positive act in Islam. So that is about the distributive issue. As for, if I quote Abdelaziz Sachedina in his outlines, so he also suggests to transfer the responsibility to ethic committees adjacent to hospitals, with the intention that there will be represented religious personalities, maybe philosophers, lawyers, and of course physicians. With regard to telling the truth to the patient, if I'm quoting Sachedina, he says, walk between the borders of telling the whole truth, part of the truth, as long as you don't disturb the recovery process of the patient. In other words, if the husband is very sick, tell him only something so that he'll be in the picture, but don't tell him the full severity of the situation. By the way, there are a lot of researchers recently on the positive influence of belief on the process of recovery. I've seen a research in medical journal from Indonesia where popular medicine was found more helpful than Western medicine in mental care. I've seen an article, I think, from Saudi Arabia about the positive or the effective influence of prayer on flexibility, on memory, especially when it comes to old age. So I think the part of the belief of the patient, and probably the physician too, should never be ignored. And I'll end with you had a table there comparing Jewish and Islamic with the pluses and minuses. I agree with the table, and I think it's reasonable what you arrived at, but I think that I do think that there are less people willing to think or in Islam about among the Muslims about the living wills or the advanced directives, but I'm not sure that the reasons are religious. They could be more cultural. Because if I may quote Professor Abul Fadl Mohsen Ibrahim's paper on the living will, more or less I saw that it is permitted, of course under certain conditions, but there wasn't any basic or principal objection to a person expressing their will not to stretch their life, especially when it was what we would call, I think, futile or just for gaining time, but nothing as far as health is considered. And if I'm moving now to the paper, 2 minutes. Wow. Okay, I must say something. I'll object the summary that I had, but I'll say something about the Moroccan immigrants in Belgium. All the reasons those immigrants provided appear again and again in other scenarios, in Egyptian fatwas and in other fatwas, for what's important, that life is a gift of Allah and it should not be destroyed. This also repeats itself many times in unwanted pregnancies. It's unwanted, but still it's a gift of Allah. Another thing is that diseases derive sometimes from immoral conduct. That's especially emphasized with the case of AIDS. I haven't seen it that much with other issues, but mainly with AIDS. That Allah is the sole healer. And from here, maybe I'll jump and I'll say I have a question for thought. At one place, we hear that pain has a redemptive power. So and that healing via suffering has to be, I think it has to be studied as a theological subject. Because this, in a way, questions, I wouldn't say contradicts, Allah's mercy and compassion. In one of the people you interviewed said, the more he suffers, the more Allah forgives his bad deeds. Then comes the question, or should come the question, then why try to erase the pain? Why try and heal? On the other hand, the doctor you interviewed in the same paper said, living while you really suffer is not living either, which brings forth the whole question of quality of life. And I think this is another question that wasn't dealt enough in Islamic medical ethics. What is the quality of life, or who should decide that the quality of life of A is not worthwhile, or of B is better than A? Who is the person that should decide? Should the patient himself or herself state that they're without quality of life, they give up certain treatments? The whole idea of, are you allowed to seek a quality of life, is also a theological question that should be raised. But thank you.
John, how do you want to proceed, since we're pushing our time to, it's 4:35.
5 minutes for questions, and I'll make a note.
Okay. The only way I know how to do this, if we're opening up to general questions, is y'all come back up, and I'll move out of the way, and some can sit and some can stand. Come on.
Thank you.
I'm going to defer to age. Deferring to age, I can sit. My teacher knows this.
Okay, just a small note, actually. He gave me the mic, John. Thank you. Just a small note, actually. When it comes to matters of life and death, it is the consensus of many Muslim scholars that a decision cannot be taken on behalf of an unconscious wife by her husband. The husband cannot take decision on behalf of his wife. It should be her children first, if they are there, and then her father, if he's there. The whole thing follows the order of heritage, you see. And they mentioned a number of things, you know, as reasons for this. I don't think one of them is getting rid of his wife, wanting to get rid of his wife. This is one thing. The other is telling the truth. I think this is also a very important thing. Of course, not all the truth can be said. And I think this is a proverb which exists in the West and it exists in the Muslim world. ما كل حق يقال, we say in Arabic. ما كل حق, not all the truth can be said. So not all the truth can be said. Part of the truth can be said, but the ethical point is never to lie to the patient. And on the philosophical question of pain therapy, I would just like to let you think about labor pains and why even doctors who are not religious are against sort of cancelling labor pains. They have got much to do with the infant-mother bond. Thank you.
I've just general question or remark. When taking patient views or family views on religion into account, I always say that it's essential to take the individual feelings and views of the patient and his or her family into account, and not those of the group to which he or she is presumed to belong. Just to give an example, I think we already established, or we already knew, that Muslim or Islam is a complex category, but I think that's important to note that Jewish, in a sense, is even more complex, in the sense that Jewish not only refers to a religion, but also to an ethnic group. And for instance, if I take the example of Belgium, in Belgium we have about 50,000 Jews living there. There are ultra-Orthodox Jews and Orthodox Jews, but then there is at least half of the population, Jewish population, is liberal, but in a non-religious sense, so not Reform Judaism or conservative, but really non-religious, free-thinking, as we call it. And of course, if you would treat these people as belonging to the Jewish group, then you would clearly miss the point. So I agree with you that there are several aspects. If we just take the example of religious Jews, I agree with you that there is a lot of in common between the different denominations, if I can use that word. And I agree, of course, that in each group there are important differences. But on the other hand, I do think that the way halakha is constructed or used in Reform Judaism or in conservative Judaism is methodologically can be different from the way an Orthodox or a typical Orthodox rabbi or scholar would use it. And I think the impression you gave us, especially specifically focused more on an Orthodox point of view, which can be recognized in an important way into other religious Jewish groups, but might not be that strong or that typical for these people.
I tried, again, when we organized our original presentation, we basically said we're going to try to represent a classical approach, knowing full well there's a range. But I would still maintain that within those who say they subscribe to religious Judaism, i.e. that they have a ritual, they have a synagogue, whether they Reform, Conservative, or Orthodox, the halachic concept is important, even though the interpretations may be different. For those who are not, and I'm one of those, I'm not a religious Jew, but I subscribe to many of the tenets of Judaism without invoking necessarily a religious, even the source of religious. And I think many Jews are like that. They don't identify themselves in a religious, observational, spirit, ceremonial way, other than high holidays and stuff that they all do. But they still identify themselves for all kinds of reasons. The thing that I find interesting in my own practice, at the end of life, I have had many people who in their whole lives did not identify themselves as religious, who will ask the question, what should I do Jewishly? Whatever that means. They want to know what they should do according to the, you might say, the rules, even though in their whole life previously they were acting in a non-observant way.
So if I could respond on the Islamic side, I certainly agree with you. My only suggestion is in terms of our desire to maintain cultural and ethnosocial competence as healthcare professionals, we must recognize that individuals come from a variety of groups, but ultimately any delegation of the patient's decision-making is with their permission. Whether they choose to say that go back to members of my family, go back to my imam, go back to whoever, ultimately the first question must go to the patient. And I reinforce and agree with you on that. And I was just trying to show that in different cultural communities there may be very different opinions. At the end of the day, even if a patient belongs to a particular cultural group, they may not share the values of the group, and you must clarify with the patient. Absolutely.
It's with great regret that I stopped this. Well, I can't make this work.
You want to use one of these?
Yeah, sure thing. Oh, no, I'm live. All right. I'm very sorry to have to end this session. Let's thank the panelists once again. I suggest we move to